Uh, Hello and welcome. I see so many familiar names in our audience as well as a lot of new ones. And I'm really happy that you've all joined us today to resume our Lown Medical Group webinar series. I'm Dara Lee Lewis. I am a general cardiologist at the Lown Medical Group, and I'm thrilled today to introduce our guest speaker, Dr. Simin Lee. You may recognize Dr. Simin Lee, who is a Brigham and Women's cardiologist, from a webinar she did with us about a year ago on Ozempic and the GLP-1 agonists. And she is also the CEO and founder of Systole Health, which is dedicated to empowering and educating women through group virtual visits. And you're going to hear a little bit more about what they do at the end of this talk and how we are collaborating with Systole for our Lown female patients to get to participate in some of these virtual programs, which are amazing. And some of you, I think, are already doing them or have done them. So you'll hear more about that. And if you're interested, we'll send you the link to get involved. But today, Dr. Lee is going to talk to us about menopause and heart health. And as she speaks, we'll save some time at the end for questions. And thanks to those of you who already submitted some online, but you can submit questions as we go along through the chat or the Q&A. So you're welcome to submit questions. But Simin, I'm going to hand it over to you.
Thank you so much. It's wonderful to be here. I loved doing the webinar last time, and I'm always so struck by how sophisticated, engaged, and curious the Lown patient community is. So very excited to be back with you today and to talk about something very important. Thanks to those of you who sent some questions in beforehand. I did my best to incorporate some of those, but there'll be plenty of time for us to talk at the end. We're going to talk about menopause, something that 100% of women go through. And even if you are a male Lown patient joining us today, you surely have women in your life, mothers, sisters, wives, daughters who will go through this incredibly, dramatic transition. And we'll talk today about how it affects the heart disease, and heart disease risk factors. So that's pretty much the agenda. We're going to review the risk of heart disease after menopause, how menopause impacts our heart, and the risk factors, our biology, and then what we can do during menopause and beyond to take action, followed by a lot of time for questions. So diving right in, what happens with heart disease and menopause? Well, the first thing that we need to be clear on is that menopause is not just a moment. It's not just a light switch that goes from being on to off. It is sort of a period of life that increasingly women are spending time in as life expectancies get longer for women. In fact, women now spend up to 40% of their lives in menopause. So it's a whole period of life, and increasingly almost half of life for some women. So what happens, interestingly, after menopause, the menopausal transition with heart disease, is that you can see here this solid line is coronary artery disease, blockages, heart attacks, and the dashed line is stroke. So two of the biggest contributors to cardiovascular disease. After the mean age of menopause, which is 51, those take off compared to even, say, breast cancer, which many women today still think mistakenly is the #1 cause of death among women, has a much slower takeoff. So they really take off after menopause. And you might think, well, these are conditions that happen as we get older. And that certainly is true for both men and women. But what we can see is that there seems to be a specific menopause phenomenon here where no matter what age you are going through menopause, whether that's in the 50s or, the 30s, not to mention the 40s, women who are on the other side of the menopausal transition, as shown in the blue bars here, have a much higher risk of getting cardiovascular disease compared to their premenopausal counterparts in the same age bracket, shown here in the orange. The other thing that's important is not just about, how long menopause is and like when we go through menopause, at what age, but how we go through it. And this is something that we review with every woman who comes through the Systole program in partnership with the Lown group. We ask about their menopause history and whether they had symptoms. So what we have come to learn from a group of investigators who've really studied this issue is that women who had frequent hot flashes, or hot flashes that were persistently frequent over years beyond the menopausal transition, you can see these groups in the red lines: frequent, and persistently frequent, and their event rate, their risk of the number of heart attacks, strokes, or even cardiovascular death that they encountered was much higher than people who had less frequent hot flashes or hot flashes that didn't really persist over time. The fancy word for that is vasomotor symptoms. So in of itself, hot flashes is an extra risk contributor. All of this together makes for a sobering big picture, which is that women, shown here in the red line, their deaths from cardiovascular causes, heart health related deaths, were plummeting in the early 2000s. And now that trend is reversed. We're seeing more and more deaths among women from cardiovascular disease, women who are spending more of their lives in menopause and who are encountering some of the challenging biology there with respect to its effect on our heart disease risk factors. So that brings us to the second thing we're really going to talk about today and go in depth on. How does menopause actually affect our cardiovascular risk factors, our cardiometabolic biology? Well, it seems to have just multi-layered effects, multi-dimensional effects. This graphic shows that really nicely, that as estrogen goes down throughout the menopausal transition, we see increases in things like weight, fatty mass, insulin resistance, cholesterol, blood pressure, the thickness of our arteries, those vasomotor symptoms, and decrease in things that, we would want to see, fat or lean muscle mass, how well we can respond to insulin, how efficient we are with burning energy, our blood vessel health, our sleep health, our bone health, something I see referenced in many of your notes that your Lown cardiologists are writing, and that the Lown team pays close attention to. So we're going to dive more into a few of the big important ones highlighted here. Let's start with cholesterol, such a big part of heart health. And here we have great data from one of the major studies in the menopause research community called SWAN, the study of women's health across the nation. This looked at 3,300 women, diverse sample, and followed them prospectively forward in time and observed what happened to key markers of heart health before and after the menopausal transition. And so what I want to show you here from their findings is that key cholesterol markers like LDL, which we traditionally think of as the bad cholesterol, the cholesterol that's very involved in blockage formation, which we call atherosclerosis, as well as apolipoprotein B, something that many of you have been very proactively screened for by your Lown cardiologists, increasingly thought to be possibly even more predictive of atherosclerosis and cardiac events than LDL. Both of those were just slowly increasing over time, and then suddenly, at time equals 0, the last menstrual period, they sharply increase. You can see that in both of these. Meanwhile, HDL, which we traditionally think of as the good cholesterol because of its anti-inflammatory properties, as well as its more limited but still real ability to scavenge LDL, the bad cholesterol, and return it to the liver. You see that going up over time, and then suddenly, during menopause, it goes down. Whereas other types of lipids, like ApoA, just slowly increase over time, implying more of an aging-related relationship rather than that abrupt step off that's really spanning the year before and after the menopausal transition. As many of you already know, and we've loved talking about this with some of you and learning about your care in this area, cholesterol, our understanding about it is really expanding. And one of the newest types of cholesterol that your Lown cardiologists are all paying very much attention to and screening you for is lipoprotein little a. This is, it's shown over here, the structure. This part here, the yellow and the red, actually look very similar to LDL and behaves very similarly to LDL, causing blockages and heart disease, whether that's, cardiac heart attacks or strokes, not to mention valve disease. What's different about it is that it's almost entirely genetically determined. It has very little to do with our diet, exercise, or our lifestyle in general. And what we see here in this review of what happens to cholesterol and cardiovascular risk over the course of a woman's lifetime, we can see that LP little a in the red curve, it suddenly goes up at key stages during the reproductive years and then again during menopause, suggesting some kind of hormonal relationship. Not shown here, but demonstrated by others, is that women who take estrogen-based hormone replacement therapy often see lower Lp(a) levels. One thing I want to stress that we suspect, that we hypothesize about, but don't yet know for sure the way we do with LDL, is that we do not yet know for sure that lower is better for Lp(a), though we suspect that'll be the case and that we will learn this as more clinical trials come out, are published, looking at Lp(a) specific therapies. But we do see it go up in menopause. Now, what about weight? A lot of women who have participated in Systole through the Lown partnership have told us about their journey with weight and have told us that, they were always fine. They ate the same thing, same exercise routine, and then, around the time of menopause, it just started going up, 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 and it seemed like no matter what they did, they couldn't get a grip on it. Well, it turns out that when researchers looking at data from that same SWAN group or research study, when they actually look at this, they see that weight tends to follow more of that linear, gradual uprising trajectory that we associate more with aging. However, what does change is how the weight is distributed, where the weight is distributed. And what we see changing more abruptly with menopause is body composition. So fat mass suddenly goes up and lean muscle mass suddenly goes down. So a lot of the time, women are telling us they feel like they're suddenly gaining weight during menopause, but in reality, what we're seeing in the research data is that the abrupt shifts are happening in how their weight is distributed and how their body composition is. You all are very fortunate to be cared for by clinicians who pay attention to this. And we've been delighted to see that body composition testing through the DEXA scan is something that's part of routine care here. Very striking, very unusual compared to other practices. Now, where that weight goes really does matter. And this may be something that you've talked about with your doctors here. What we see is that having more fat, less lean muscle in menopause, that tends to be showing up as visceral fat, which is fat that is on the organs. So not all fat is created equal. And we can look over here to understand how or why. So, a lot of women are used to hearing this concept or framework of apple shape versus pear shape. When somebody's pear shaped, their fat shown in the yellow here is really more under the skin rather than inside the body, inside the abdominal cavity. And when that's the case, it's very hard for the fat to build up on the organs. That's what we mean when we say visceral adipose tissue or visceral fat. And so these people who are pear-shaped, they tend to have more of a normal metabolic profile, less insulin resistance, less high blood pressure, high cholesterol, all those cardiac risk factors. However, people who are apple-shaped, and this is much more common in menopause, their fat is getting stored inside, not under the skin, but inside the abdominal cavity, where it can easily deposit on the surfaces of organs like the liver, lean muscle, the pancreas, but importantly also the heart, where it can cause some local inflammation and accelerate blockage formation, not to mention cause problems with things like heart failure. This alters our metabolic profile, makes it easier for us to get prediabetes and diabetes, and ultimately to get cardiovascular disease down the line. So we see that the weight just goes up gradually, but our body composition abruptly changes. And the implications of that are that it tends to increase our cardiovascular risk because it tends to get stored on organs rather than just under the skin. This phenomenon of body composition change and increased visceral fat turns out to also be related to some blood vessel changes that we observe in menopause. So we're shifting gears to another type of risk factor here. What we have seen is that arteries, especially in people who have more of that visceral adipose tissue, tend to become thicker and stiffer during the menopausal transition. These investigators looked at, again, the same patients from SWAN, and they showed that carotid artery intimal media thickness, and I have a graphic here to show you what we mean by that. Here are the layers of a blood vessel wall. The innermost layer is the intima, okay? And when we look at that on ultrasound, right here, and some of you have had this study, we can measure the thickness. And if it's very thick, it usually tells us that there's some plaque there. or some early changes on their way to plaque formation. And so what we see, that measure, carotid intima media thickness, tells us about the health and stiffness, the thickness of our blood vessels. Before menopause, 2 years before menopause, that number, that thickness is pretty flat. Then during menopause, it is sharply increasing in slope and then leveling off again after menopause. So that's the thickness of the carotid artery. The stiffness also changes. We see here that when measured by ultrasound, women, regardless of, their race, but we see possibly higher risk changes in Black women, experience a similar phenomenon where the stiffness is more or less the same or just gradually increasing before menopause, then sharply increases during and levels off after menopause. So more thicker arteries and stiffer arteries, particularly in people who are experiencing those cardiometabolic changes. Now, you might wonder or think, well, naturally, this means that many women in menopause are headed for high blood pressure. And it's interesting that the research here is actually kind of mixed. The data is mixed. This is a big review published in one of the American Heart Association journals focused on hypertension. It's called Hypertension. And these researchers looked at every study on this very question. Does menopause lead to hypertension? And they looked at different types of studies, and they noted that the results are conflicting. However, more recent data published in 2020 followed women's blood pressures and men's over their entire life course. And they noted that women tended to see steeper increases over their life course. The slope was steeper, and that steeply increasing slope, that those changes from baseline started much earlier than a lot of women are accustomed to thinking about, when they might be busy with expanding their family, with a career, with being young, not really worrying about their blood pressure. So women tend to really have steeper increases in their blood pressure over time, even if we haven't been able to firmly demonstrate a link to menopause. You'll see that a lot of these increases do sharpen around the median age of menopause in the low 50s. But again, this is just something to be aware of, and why your Lown cardiologists are so excellent about paying attention to your blood pressures, both in the office and for those of you measuring at home, what they actually are at home. So that's an overview of how menopause is affecting some key risk factors: weight, cholesterol, blood pressure, and our blood vessel health. Okay. Now, what to do about it? Some of this is very sobering and a little bit, you might be worried whether you have gone through menopause yet, whether you are going through it, whether you've already gone through it, but there are other women in your life that you worry about. What can we do? Well, just like anything at Systole and Lown, we really believe in a comprehensive approach that marries, both evidence-based medication management for the right patient at the right time, as well as lifestyle change. And so let's talk about the medications first. And some of this will be, old hat to some of you. You'll be very familiar with this, and some of you might just be curious. So when it's excess weight, we are fortunate to be living in an age where we have treatments that actually work nowadays. And Dr. Lee Lewis mentioned that I'd spoken previously to this community about GLP-1 medications like Ozempic and Mounjaro, but that certainly has become a dominant treatment category for helping people with their excess weight and managing it in addition to lifestyle. And we don't want to forget, and some of the patients who have come to us through Lown have shared their own personal experiences with this, that there are surgical treatment options as well that still are quite effective, even more effective, honestly, than the GLP-1s, have some added cardiovascular benefits and are probably increasingly underutilized. So we do have options for weight management. When it comes to cholesterol management, we have a whole menu of options. It's very easy to get bogged down into conversations about statins and, the risk of side effects, fears about side effects, and those are all very valid and understandable. But again, we're very fortunate that medicine has advanced and given us more options. In oral treatments, we have ezetimibe and bempedoic acid now. When people have high triglycerides and are at risk for heart disease, we also have something that can help with that. And we also, for people who either can't tolerate statins or are not at their LDL cholesterol goal, despite being on a statin and other therapies, are these injectable treatments called PCSK9 inhibitors, which have been very effective. For blood pressure, there's so many treatments as well, but what I want to emphasize is that there are a few that are first line. ACE inhibitors like lisinopril, losartan, diuretics, which are fluid pills like hydrochlorothiazide or chlorthalidone, calcium channel blockers, amlodipine. Beta blockers like carvedilol, atenolol, metoprolol, not traditionally first line, still can have a role to play. And some of these medications offer additional benefits that should be taken into account beyond just the blood pressure. So those lisinoprils and losartans, turns out they can help a lot in patients who have diabetes, who have kidney disease and or heart failure. So we try to think about the whole picture whenever we're trying to help somebody with this risk factor that has cropped up during menopause. Finally, insulin resistance. Whether it's prediabetes or diabetes, we have a lot of options here. Metformin is certainly one, has been around for a long time, very safe, generally well tolerated. Insulin for people who are really struggling with their blood sugar control and have dangerously high blood sugars. Those GLP-1 medications that we talked about for weight management, they started out as diabetes treatments. And now there's been so much progress in the research there showing us that if people additionally have excess weight, sleep apnea, fatty liver disease, kidney disease, or cardiovascular disease, these GLP-1 medications can help reverse biology or at least mitigate risk when it comes to cardiovascular disease. And then finally, there is another category kind of similar to the GLP-1s. It started out as a diabetes medication. These are the Jardiances, the Farxigas, that also turn out to have dramatic benefits if somebody has heart failure and kidney disease as well. So all to say, there's a broad menu of treatments that need to be tailored to the right patient individually in a personalized way to help them with the risk factors that we know do come up quite frequently during menopause and beyond. Now, there was a question submitted about hormone replacement therapy. What about that? And so let's talk about that. That's another treatment category that is an important part of this conversation and topic. Hormone replacement therapy, or HRT, was honestly standard of care until a few studies came out. So you see that the number of prescriptions really uptrended. At one point, just before the year 2000, it was close to 100 million prescriptions per year. It was really just standard, and people thought that this was part of, actually helping women be healthier with respect to their heart health. But then this study, the HERS trial, came out in 1998 and showed that healthy menopausal women, they didn't necessarily get a cardiovascular benefit from being on HRT, from being on estrogen. So prescriptions dropped off a little bit. But then a big study called the Women's Health Initiative was published, suggesting or showing that there was an association between estrogen-based hormone replacement therapy and adverse or dangerous cardiac events like strokes or lung clots, which we call pulmonary emboli, as well as breast cancer. And after that, in a field and profession where change often happens slowly and painstakingly, change happened very quickly, and hormone replacement therapy was almost not prescribed at all. More recently, we've been revisiting that. There's been new data showing us that in certain cases, depending on the patient's risk profile, and depending on how old they are, depending on how recent menopause was, that it can be considered and it can be safe. So the way we're approaching that now is shown here. What we do is we say, okay, if you are under the age of 60, and if menopause was less than a decade ago for you, then it's reasonable to take this risk-based approach where we look at, your risk factors. And if you don't really have cardiovascular risk factors, your actual predicted risk is low, you don't really have high risk for breast cancer, that population is generally safe to take oral estrogen-based hormone replacement therapy. On the other side, if somebody has already had a heart attack or a stroke or has blockages in the legs, we actually do count here. This is probably something up for debate in the community, but some cardiologists consider a coronary CT scan showing non-obstructive, like mild blockages to be in this category. But basically, if you've had an event before, a lung clot, a leg clot, breast cancer, you're higher risk. And we try to avoid oral estrogen-based HRT in that category. Most people we take care of are in this yellow middle category. Nothing is straightforward. They have cardiovascular risk factors. They may have risk enhancers like autoimmune disease, lupus, rheumatoid arthritis. They may have a high risk for breast cancer. They may have some coronary artery calcium on a calcium score. And if this is the case, we try to avoid the oral, which is more vigorously absorbed by the body, the entire body, and prefer instead a patch, which does not seem to get into the body at such high doses. It's shared decision making. The patient is and the doctor talk about this together, but this is our new approach here. We do acknowledge that if menopause is pretty far in the rearview mirror over a decade ago, we do try, it is higher risk to use oral estrogen, and we try to consider alternatives. And what some of those alternatives are, I didn't have time to put this onto a slide, but there was a question submitted beforehand. What those alternatives are, there are antidepressants that turn out to help a lot with some of those vasomotor hot flash symptoms, not to mention mood and cognitive symptoms. But there are also novel treatments that are being developed that don't have as many side effects as some of those non-HRT alternatives. And that is a relatively new category of drug development. I think there's one on the market now and another that is undergoing FDA approval. So this is a hot area of research, more to come. There are non-hormonal alternatives and some newer drugs that are in the pipeline. So that's all the medications. But in the spirit of both medications and lifestyle, let's talk about lifestyle and the role it can play in managing all of these cardiovascular changes that come up during menopause. For this, we turn to a framework called Life's Essential 8, developed by the American Heart Association, that really serves as a compass, a guide, an overview of the 8 key dimensions of cardiovascular health. And this is how we structure a lot of what we do in our programming, our partnership with Lown. So the bottom is a lot of what you talk about with your Lown cardiologists and doctors in your visits, managing your risk factors and knowing your numbers and making sure your numbers are at goal. So for blood pressure, we like to see people under 130/80. For cholesterol, if you are higher risk or you have had a cardiac event and heart attack in the past, a stroke, we like to see the LDL under 70. If it's weight, we like to see a BMI under 27. Under 25 is even better. A hemoglobin A1C of under 5.7 usually means a normal blood sugar range. So those are the risk factors, controlling those, managing those, even knowing where we stand in the first place. The top half of this wheel are things that are more within our control. Not saying that that means it's easy, but things that we have a little bit more agency over. So substances we put into our body, when we go to bed at night and how much sleep we get, the food that we eat, how much movement we get in our daily routine. And so we'll talk a little bit about, we talk a lot about these in our program, and this all together makes for a good, healthy cardiovascular lifestyle. Now, what's interesting is that people have studied how this Life's Essential 8 relates to mortality and longevity. And it turns out if you consider kind of lifestyle to be a medicine here, and we do, it turns out that with every dose, with every one of the Life's Essential 8 that you check off, there are millions of deaths that are averted every year in the United States. And the same is true for deaths specifically related to cardiovascular disease. So we call that a dose-dependent relationship, where the more of Life's Essential 8 you have in your life, the longer we live as a society. So this is exactly why we are partnering with Lown to help women with this, because we know that although it makes a big difference, it can help bend the curve and reduce our risk. A lot of the changes with respect to diet, nutrition, movement, sleep, substances are really hard to make in practice. And so what we do for those of you who haven't, been aware of this yet, but who might be interested in joining us, and we would welcome you, is we do a lifestyle medicine approach. We have these hour-long virtual visits with me and our health coach and a group of women who are in the Lown patient community. And we meet every week for 6 weeks, covering, some key high quality curated education and information on big drivers in lifestyle of heart health. So stress, nutrition, movement, and sleep. We talk a little bit about substances depending on the group's interest. And throughout the program, women not only get that education, but they get coaching, motivation, accountability, and personalized support. And we do this all hand in hand with your Lown team so that it complements the care that you're getting in your visits. So we've been doing groups. We've been loving meeting some of you and working with some of you. And if any of you are interested, Dr. Lee Lewis and the Lown team will provide a link afterwards to sign up, and we'd be happy to get you situated and on board. So that's sort of some of the material we wanted to go over today. But at this point, I will stop speaking and welcome any of you to submit questions that this prompted for you. And I'll do my best to answer them.
Oh, thank you so much, Simin. That was amazing. You could stop sharing the slides and then they can see us. And I do want to add, for those of you who are interested in this program, that at least until July and possibly longer, it's a pilot program that was generously supported by a grant from Ira and Judy Rosenberg, who are two of our patients, one who's passed. And so we're covering the cost for our patients, so it's no cost to you at all, at least till July. After that, there may be a small copay, but that's just one more reason to jump on this sooner rather than later, because it's a bit of a deeper dive into all these things you were talking about. So thank you so much. You covered so much, and a lot of questions came up, and we're going to get to the questions in the chat, but I just wanted to clarify one thing, which is, because I think there was confusion in one of the questions that was submitted. The main reason that people use HRT in menopause, hormone replacement
Yes.
therapy, is to relieve hot flashes, right? I mean, that's
Yes. Symptoms.
proven, right? And the second benefit that's definitely non-controversial is it helps bone strength. So those would be
Mm-hmm.
the two main reasons people use it. And then what has been taken off the table is that it's no longer felt to be useful to help reduce cardiovascular risk. Then there was a
Right.
question, might even increase it.
Right.
But what's interesting is estrogen. So it's obviously we're talking about menopause is the decline of estrogen production by the ovaries, and that drops pretty precipitously at the time of menopause, but it begins in your 40s typically and then
Mm-hmm.
accelerates when your ovaries just stop producing estrogen altogether. Is that as the estrogen drops, our lipid profile looks much worse, right? And our
Mm-hmm.
clotting risk goes
Mm-hmm.
down, right? So then
Mm-hmm.
when you give estrogen, it might make the lipids look better,
Right.
but the clotting risk goes up.
Right. Right.
So just
Exactly.
saying, you've already covered that, but I just want to clarify for the audience because I think there's a lot of confusion about why would you take it? Well, it definitely relieves hot flashes and it definitely helps bone strength.
Yes, and that's important. And how bothersome are those? We talk about this with every Lown patient we meet, and they recall their experience with menopause, and some say I had terrible hot flashes and nothing was given to me, and some say, yeah, I mean, I didn't really even realize I was going through it. So I think if patients are very symptomatic, and they want hormone replacement therapy to treat those symptoms of menopause or to help with bone density, then that triggers us as cardiologists to try to help guide them and their hormone replacement therapy prescribing physician on what is the risk and what is the best way forward. Is it oral estrogen? Is it a patch? Is it an alternative altogether to keep them overall safe and healthy? But
Perfect.
we don't use it to treat or prevent cardiovascular disease. Increasingly people talk about it as a way to help with weight loss. That also we don't have strong evidence for as well.
Perfect. Thank you. Okay, great. So I'm going to start with some of the questions that are in the chat. What labs should I be monitoring if I'm worried about my heart risk?
Yeah, this is such a great, I was just at a grand rounds where a physician named Martha Gulati from Cedars-Sinai out in LA, who is one of the leading experts on women's cardiovascular health, came. She did a grand rounds. She did a sit down afterwards. And she and another local expert, Dr. Michelle O'Donoghue, who does a lot of research on that lipoprotein little a, had a back and forth about this very question. And it was very interesting to hear them talk. And I think most agree that there's actually a lot of, knowledge and power in some of the things that many of you already get. A routine lipid panel. I think I would add to that these days a lipoprotein little a.
Yeah.
And possibly related to that, and there's a big New England Journal paper that advocated for lipoprotein little a, high sensitivity CRP, and the lipids. I mean, those three are powerful. We do know that kidney function, which cardiologists, notoriously undervalue and brush to the side, it does mean a lot for our long-term cardiovascular health and risk. So, and in fact, the newer risk prediction equations actually take that into account explicitly. A weight, a blood pressure. I mean, these are basic things, but we can learn a lot from them. And you are all, once again, very fortunate to be in a practice where things like the Boston Heart Labs are just part of the, routine evaluation and include that lipoprotein little a, the cholesterol panel, the A1C all together. So, I think that that's usually where I would start. And outside of labs, a good family history, which I've seen in every single one of your doctor visit notes from Lown, can also tell us a lot. We all know, and you all know, that no medical issue is well, very few medical issues are, a straightforward, just genetic or just lifestyle related. It's often an interplay. And when we hear that somebody has many relatives who died young of heart or had heart attacks young or suddenly died, that's a red flag to us as well. So some basic labs, honestly, a good family history make for a lot.
Great. And then all the things you mentioned too about monitoring blood pressure and talking a lot with your doctor about ways to stay active and keep
Yes.
healthy foods going in. Okay, perfect. How long can you take oral or transdermal hormone replacement therapy?
How long can you take oral or transdermal? Well, I mean, I think that again, just coming back to that, what is the role that it's playing? If it's to treat the symptoms of menopause, then, and somebody is low risk enough to be on either oral or transdermal estrogen, then we would use it for treatment as long as the symptoms last. But if the symptoms resolve, then there doesn't necessarily, have to be a reason that they're on it, unless, as Dr. Lee Lewis mentioned, there are bone strength, bone density concerns beyond typical treatments for osteoporosis.
Okay, perfect. And so periodically you might try tapering the dose down a little bit, see what's under there, because if the hot flashes have resolved, which they often but don't always do over a period of years, you don't need to stay on it anymore. There's no benefit to it unless
Right,
there's a major bone strength issue. Okay,
right.
great. Since we're on the topic of hormones, can you talk a little bit about the role of progesterone? So we talk about
Yeah.
estrogen versus estrogen plus progesterone.
Yes. So progesterone, also plays a big role, not as much as estrogen in all of the cardiovascular risk factors and heart disease itself. The way it's really come into the conversation is that people used to just get conjugated estrogen alone, just estrogen for hormone replacement therapy. And then in the 70s, researchers started noticing that that was increasing the risk of endometrial or uterine cancer. And so that led to the introduction of a combination of estrogen with progesterone to balance that out. So progesterone kind of helps counteract while still allowing you to get the benefits of, and the symptomatic relief from having estrogen. So now it's typically standard to have them together, unless, for example, it's the estrogen patch or some kind of vaginally inserted estrogen.
Okay,
Great
great.
question.
And some people take progesterone alone. Is it felt to be useful for some of the symptoms, like the sleep disturbance or?
Yeah, I would ask. I haven't encountered that as much anecdotally. That is what I've heard, but I'm sure you and Dr. Hedgepeth have more experience with this. I'd be curious to know what your patients have
Yeah.
reported.
No, I think it's interesting. I think we could talk hours on hormone replacement therapy because it's a little bit become a bit of a wild west in terms of compounded
Oh,
and
yes.
topical and so many things that I think the um, hype got a little bit ahead of the science there. So I think anecdotally, some people do feel it helps with sleep, and to my knowledge, there's not a lot of data about that.
Yeah. Yeah, there's a company, there's a telehealth company just focused on menopause, and their team wears shirts everywhere that says menopause is hot. And I think you're right. There's been a little bit of a hype factor here, and it's been great for validating women who have felt like their symptoms or concerns and real physical changes that were happening during this transition were overlooked or brushed aside. But as physicians and talking to patients who take your care very seriously, we never want to let hype sort of guide medical care when it
Yeah,
comes to our own patients.
totally. Um, there's an interesting question here about the risk of cardiovascular disease in women who have hysterectomies, but I think what they mean is hysterectomy with removal also of the ovaries. So we call it
Yeah,
hysterectomy, oophorectomy. So hysterectomy alone, if you leave the ovaries intact, would have no bearing on any of this.
no,
But
exactly.
let's say someone in their 30s or 40s has their ovaries removed and goes into premature menopause.
Then that is actually considered a sex-specific risk factor for heart disease down the line, which is why it's so important for all of us in the cardiology community to be asking women about their obstetric and menopausal history. Because if you have lived a whole decade longer than the average person without estrogen, then your lifetime exposure to the risks of being without estrogen is higher. Your LDL might have been higher that whole time. Your blood pressure might have sneakily been higher the whole time. You might be experiencing some of those body composition changes. So it's an important thing for us to note. And I do think that sometimes the gynecology community is pretty good about recognizing that those patients may benefit from hormone replacement therapy for a period, but we call that surgical menopause. And early menopause, whether it's surgical or medical, biological, is a risk factor for heart disease.
So I think, yes, the standard of care now would be to replace at what we call physiologic levels, sort of to reproduce the levels that you'd normally see in a woman of the age of 40 or 45. And then at the age when someone would normally go through menopause, you would try to withdraw those hormones and see if you can kind of mimic a natural menopause, right? And
Hmm.
see. But yeah,
Hmm.
absolutely. I think until that became recognized, women who had premature menopause from surgical reasons or from any reason had premature cardiovascular disease.
Hmm.
Okay, so interesting. Um, Someone is asking whether GLP-1s, so this would be Ozempic-like meds, can they help with menopause symptom control?
I haven't seen GLP-1s. I haven't seen anything about GLP-1s helping with, say, vasomotor, hot flash
Yeah.
symptoms. Of course, some people, talk a lot about the non-hot flash symptoms of menopause, like we were discussing earlier, sleep disturbance, even brain fog, just sort of like cognitive impairment. And there are a number of patients who report that with the interruption of what is colloquially referred to as food noise on GLP-1s, appetite suppression, that they're able to direct more cognitive energy to their jobs, to their family, and just not be thinking as much about, what am I gonna have next? So I think that maybe it might help a little bit with that. Um, However, I think that otherwise, it's not so much symptoms as helping address and even reverse some of those cardiometabolic changes that happen with body composition, excess fat deposited around the midsection, high blood vessel stiffness, and cholesterol that has slid in the wrong direction.
Yeah. And I think that's so important because so much of what you've talked about today is relevant to menopause, and so much of it is also relevant to everybody listening, men, women, young, old. It's things that we all need to be aware of to keep our heart healthy. It's just that some of
Exactly.
them really kind of get drastically different around the menopausal transition.
Yes.
One more question on hormones, and then we'll talk about some other things. But people use oral contraceptive, which is often usually estrogen and progesterone, in for other reasons, obviously for birth control. Can long-term, someone's asking, can long-term use of birth control lead to increased cardiovascular risk?
We think so. I mean, we see patients, this is exogenous estrogen, and although a lot of the birth control formulations now keep it at a low dose, just low enough to suppress ovarian function, it is still something we take note of when someone comes in with a pulmonary embolism or a deep venous thrombosis. So we think that long term, the longer the exposure to exogenous estrogen, the higher the risk of clotting events like that. But I want to sort of, couch that, or just make the caveat that frequently the doses are very, very low.
Yeah. And it wouldn't necessarily cause what we consider atherosclerosis or hardening of the arteries.
Exactly.
But in that moment, a blood clot in the leg, a blood clot in the lung, that risk for sure goes up, which is one of the reasons we tell people on birth control or at hormone replacement not to smoke, right? Because it
Right.
doubles down on the risk of a blood clot.
Yes.
Okay. All right, great. And someone here is asking, okay, what are the effects on coronary disease risk of a hysterectomy after menopause? And really,
Yeah.
because again, if you're removing the ovaries, which is hysterectomy is removing the uterus, oophorectomy is removing the ovaries. Even if you remove the uterus and the ovaries, if the ovaries aren't producing estrogen, it's not going to
Right.
make
Unless
much
it,
difference.
exactly. Unless
Okay.
it was done very early.
Can you speak to why would a postmenopausal woman's cholesterol levels increase so dramatically over a year or so? This person who's writing in said the total cholesterol went from 150 to 245. The LDL went from 86 to 132 to this person and her sister and brother as well. So the
Oh,
brother
wow.
too.
Oh, wow. Yeah. So, I mean, it wouldn't explain anything in the brother unless there's more to his genetics than we know. But I think that those kinds of, those kinds of increases in LDL, decrease in HDL, we see that sometimes in menopause. Of course, if it's a very dramatic shift, even, 1 year to the next, we might also wonder, is there lab error involved, fasting, not fasting, although increasingly we think that's less important. And then, sometimes one thing that I didn't mention, well, I did mention that LP little a is structurally very similar. It physically resembles LDL. And what we've come to realize is that it will often get measured as LDL cholesterol. So if LP little a is increasing during menopause, that might be another reason. If it's suddenly high, that could be a reason, a contributor to a greater than expected LDL increase that isn't otherwise explained by lab error.
So in this case, the HDL actually went up.
Mm,
I didn't tell you those numbers from 59 to 91 with menopause, which typically the HDL would drop,
go
right?
down.
Yeah. So that whole
Yeah.
thing sounds kind of unusual and
And possibly an error. So, I
uh,
think if there's confusion, there's no harm in just repeating. That
yeah,
would probably be a good first step. And making sure that all those other, cholesterol markers are checked just in case it's influencing the numbers that you're seeing.
yeah, because that would be unusual. I think it's usually much more gradual.
Yes.
Okay.
Yes.
Um, so here's another question. So you talked about how people tend to gain more fat, especially that deep belly visceral fat as they go through menopause and lose muscle mass. How do we fight that trend,
Yeah.
which nobody wants? Is it a question of how we eat? Is it a question of how we move?
Yes, that's a great question. I see two in there about diet, nutrition, and movement. And these are great questions to be asking, the right questions to be asking. So, I think with the body composition changes that happen in menopause, less lean muscle, more fat, right? And muscle is more metabolically active. It burns more energy when you're just sitting around doing nothing than fat. So if we don't change anything about what we eat, how much we eat, our movement, and particularly within the realm of movement, like how much we're doing to build up muscle, then we will have an energy surplus. We will have excess calories, we will gain weight. And that's something that a lot of women are all too used to seeing. You saw that linear increase in weight over time. So what can we do? We can certainly try to to modify how much we're eating, and moderate. That's obviously easier said than done and very difficult. We can also try to strive for a nutritional approach that helps just naturally contain some of the calories that go in while also promoting more heart health all around. So these are diets like plant-based diets, Mediterranean diet and DASH diet often overlap a lot with a plant-based diet, which is much heavier on vegetables, fruits, plants, as well as it doesn't mean just eating. We say this in our program all the time. You don't have to be eating like a bunny, lettuce all the time, actual protein, but just protein that comes not so much from animal-based sources, even if it's poultry, but rather, plant-based sources as much as possible. So, aligning our nutrition around those highly evidence-based nutritional approaches, diets can help contain the calories and maximize nutrients that promote heart health, minimize nutrients like saturated fat, sodium that work against us for heart health, and help, combat some of those metabolic changes. However, at the same time, not only do we have to try to get protein are the building blocks for making muscle, we need to actually do things to take that protein and make muscle. So, movement, I personally got the running bug. I love to run, but, and runners are notoriously terrible about this. So I do have to practice what I preach more. But strength training is a big opportunity for women who are looking to reverse some of these changes. So eat more protein, get that protein from plants, but then turn it into muscle by engaging in strength training. And the other advantage with strength training, particularly if it actually means picking up weights rather than just using your body weight, is that it can help strengthen, it can help with bone health. It
Yes.
can really help, sort of prevent some of the osteopenia and osteoporosis. So the broad strokes, that's what we try to advocate for, and we try to work with people within the program to achieve on a week to week basis.
That's so important. And I tell my patients all the time, like, there's two ingredients for muscle. It's strength training and it's protein. All the strength training in the world without protein, you're not going to build muscle. And all the protein without moving isn't going to build muscle. And it's hard, right? Because really, I don't know that many people who love the strength training, but you got to do it for your bones, for your heart, for your blood sugar, for everything. And I think with so many people on these GLP-1 agonists where they're developing a smaller appetite and nausea,
Yes.
we see a lot of people who are cutting out protein out of their diet and not getting enough protein and not just losing weight, which
Mm-hmm.
sounds great, they're losing muscle too.
Mm-hmm. Mm-hmm.
So it's
Yeah,
really
it's
important,
true.
right?
Any effective weight loss will mean muscle loss. And so if we want to sort of, be strong and feel strong, then and not have all of these metabolic issues, then that does mean actually strength training. And I think one thing that we see is that one size doesn't fit all. There are a lot of different ways to strength train. We've had women from Lown come through and their strength training is lifting 50-pound bags of soil in this spring and they're gardening. And for others, they're doing kettlebells and, like something much more kind of conventionally in the strength category. So we try to just work with everyone to find what will work for you and not feel like a drag, but actually be a little joyful, stimulate some curiosity. Okay, I did this. What else can I do? How can I do a little more next week?
I have so many women patients who do yoga and Pilates. What do you think of that?
It depends. I think yoga in particular is such a big, vast world unto itself. And so types of yoga that involve, sustained maintenance of, positions that are essentially a body weight strength exercise, I'm all for it. There are varieties of yoga that emphasize mindfulness and stress reduction more, but aren't as necessarily physically intensive. So I think just being really honest with yourself about how much, all strength training is it's working a muscle against resistance. And, for some yoga types of yoga, that resistance is your body weight. You're working, the load is the body weight. But in other types of yoga, it's more about just sort
Mm.
of calming the mind. And as long as we're honest about what we're actually doing in a yoga or Pilates class, then we can account for it properly.
Okay. Yes. I think we probably all know what kinds of yoga classes are really working our muscles, especially if we're sore the next day. That's
Yes, it's a
good.
good sign.
Um, and any quick comment on what type of protein and how much protein?
Yes, great question. So the sort of, I think US Dietary Association, recommends or states as a normal range of protein intake as zero point 0.8 grams per kilogram up to 1.2 grams per kilogram. Now, of course, they couldn't provide this in pounds, but we won't fault them for that. Easy calculation. But that's like sort of your normal range to just have a normally functioning body. If what I share with my female patients going through menopause, kind of grappling with some of these body composition changes is that if you want to push back on that through greater protein intake in the diet and then taking that protein and converting it into more lean muscle, then we probably need to target the higher end of that range or possibly even, what some athletes do, which is more in the 1.2 to 1.5 grams per kilogram range. And that, might not be something that happens overnight, and that's totally fine. But just recognizing we might actually need to be looking to the upper end or beyond is important as long as there's no kidney impairment that makes protein a little challenging. And for sources of protein, you know, for plant-based sources of protein. And I went through this transition myself. I mean, like I grew up eating meat just like the average American every single night, chicken, steak, whatever. And we went through this once I was in cardiology fellowship and I started seeing all of this research. And it was hard for my male spouse who cares about like being strong to lift up our children. But we just started with trying, especially in the winter, it's easy soups, chickpeas, lentils, beans, that's very easy. Instead of a burger, the veggie burger that has all of those legumes packed in. It turns out there's about 800 ways to prepare tofu without it feeling like some slimy foreign substance. It can be scrambled like an egg. It can be barbecued on a grill. It can be baked on a sheet pan. And so we've been trying to learn more and experiment. And that's sort of the philosophy or mindset we encourage the Lown patients who come through Systole to adopt is just experimentation. Get curious, and try something. And if it's not your thing, that's fine. And then maybe try something else. But those are some great sources, not to mention edamame, seitan, other soy products, and protein powders are fine. I think I just put an asterisk there because they're not all created equal, and some recently have come under scrutiny for having heavy metal, contamination. So we try to get it from real food as much as possible.
Perfect. And fish?
Fish is great. Fish is great. But we always need to be thinking a little bit about how it's prepared. Obviously, like breaded, battered, fried fish is a different beast than a baked or broiled or lightly pan-seared salmon. So, I think that fish definitely offers a lot in the way of anti-inflammatory properties and helping contain some of our lipids and everything. So, definitely that is a source of animal-based protein that can be very heart healthy.
Perfect. And egg whites and cottage cheese are sort of some favorites as well, right? You get some
Yeah.
calcium in your cottage cheese.
Exactly. Exactly. And dairy is an interesting thing. I mean, I think we just need to know is what is this is there sodium? Is there saturated fat? Is this the full fat version of the Greek yogurt with a ton of granola, or is this the non-fat version with maybe just a few nuts sprinkled on top? So and I think what I always stress is we're not out here to evangelize veganism. I mean, if you're vegan, great. But I think just how can we be 1% better? How can we just make a little change this week and get curious? And so I see a question about just, healthily prepared chicken. I mean, that's better than a steak. Is there a way to explore plant-based chicken, which by the way exists and you can get it in the grocery store? So, I would just challenge all of us to think a little bit about whether there's a substitution or some kind of little change that we can incorporate on the food front to be a little heart healthier as a community.
Thank you. All right. Well, unfortunately, there's more questions, but we have run out of time. So I think we're going to need to have another session on nutrition. That's a lot of questions on nutrition and hormones.
Yes, yes.
Wow, we sure covered a lot. You covered so many things about what menopause is and why women should be aware that as we go through the menopause transition, so many things change in our bodies, some of them good, some of them bad, but we have to be particularly aware of what it does to our heart risk. So our cholesterol, our blood pressure, our blood vessels, reactivity and stiffness. So thank you for highlighting that and then helping us look at ways with medication or with lifestyle that we can help mitigate those risks. So I appreciate so much.
Oh, thank you
Uh,
for having me. And thank you for this wonderful partnership. We look forward to meeting some of you in our program. And we are just so proud to be standing next to such a wonderful care organization and its patients who care so much about the right things.
Well, thank you. And I want to thank everyone in the audience. Your questions were fabulous. Thank you for your engagement. And I hope you'll all fill out a very brief survey at the end of this. And we also solicit from you any topics that you'd like to see us cover in future webinars. So thanks to the audience, thanks to you, Simin, and have a wonderful rainy day.
Take care, all. Thank you.